Greetings, everyone, and welcome to the second part of my presentation on my views of prescribing psychoactive medications. And the first part has been recorded and is available for view. So we will dive into the second part with a short amount of review. And I just wanted to review again some of the classes of drugs that we've been talking about, including attention-altering drugs such as Ritalin, which is methylphenidate, amphetamine, Adderall, which amphetamine and mixed amphetamine salts, atomoxetine, which is not a stimulant, but is a selective norepinephrine reuptake inhibitor, and modafinil, which was created to keep fighter pilots awake for a really long time. Then, of course, there's the anticonvulsants. And I think primarily what they do is slow down people's thinking so they're not as impulsive. And primarily they're sodium channel blockers. So there's valproic acid, also known as Depakote, carbamazepine, which is also known as Tegretol, oxcarbazepine, also known as Trileptal, lamotrigine, also known as Lamictal, topiramate, also known as Topamax, and of course there's a few others by now. One of the anticonvulsants that has the least psychiatric benefit and the most psychiatric side effects is Keppra, which I've observed our current generation of neurologists love to use. I think primarily because you don't have to worry about levels. And of course, in our siloed healthcare system, as long as it treats seizures, who cares if it causes psychiatric side effects, because that's someone else's department. And of course, gabapentin and pregabalin are also anticonvulsants and less efficacious against mania, but useful for anxiety and alcohol cravings. So, of course, there's lithium, which is in a class by itself. So, as we've talked about before, for the most part, medications in any particular class are essentially equal in terms of their efficacy, and what differs are their side effects. So some people can tolerate some side effects better than other side effects. And on occasion, the side effects can be helpful for some people. For example, I saw someone who was psychotic, in a state of psychosis, disorganized thinking, paranoia. And we wanted to keep her out of the hospital. And she wasn't sleeping and she was very nauseated. So I chose chlorpromazine for her because it treats nausea very, very well. It was originally developed for nausea. And it also makes you sleepy. And it turned out to be very effective. And she didn't need a very large dose. And we kept her out of the hospital. And that is the main goal for me in using medication, is to keep people out of the hospital. Because in this country, psychiatric hospitals can be brutal places. Not always, of course, but not necessarily spaces for healing. And so if we can surround someone and with support and psychotherapy and community building and occasionally medications and keep them out of the hospital, then that's a great thing. And perhaps in other programs, we'll talk about alternatives to psychiatric hospitalizations, which exist, such as Gould Farm in Massachusetts and Windhorse Ranch in Massachusetts and Colorado, and a program near Asheville, North Carolina, whose name I'm blocking right now, and multiple other programs. However, they're quite expensive, often $20,000 a month or more. And typically insurance does not cover them. So they're not really a very available resource for the majority of my patients. So we do resort to medication, short and sometimes long term, to keep people out of hospital. And I think probably the most important thing that we can do is to help people get to sleep. Because if you go enough days without sleeping, crazy things happen. And that matters. So we always have to be aware of the side effects. For example, imipramine helps anxiety, but also gives you a dry mouth, constipation, and urinary retention. So that's not good. However, the hard part about this is that it doesn't do it for everyone. And to my knowledge, there's no way to figure out what medication will work best for what patient with the least side effects. And as I mentioned previously, the gene site testing tells you how rapidly or slowly someone metabolizes a medication, but that has nothing to do with how effective it might be. And people get confused by that. They think that this gene site test will tell them what the right medication is, but it doesn't. So I only use it when I have a medication that's getting near the top of the dose that the manufacturer recommends for the maximum dose. And I wonder, and it's been partially affected. And I wonder if I can go beyond the manufacturer's recommended dose because maybe they're a rapid metabolizer. So, and we'll get into more of this later. So lithium is interesting. And, in Saratoga Springs, New York, there's a substantial amount of lithium in the spring water. And Saratoga Springs in the 19th century was a historic site for disturbed people to travel to the spas to become calm and peaceful. So we know that lithium reduces manic symptoms. It helps with depression. It reduces suicidality. However, it's toxic, can be toxic to the kidneys and the thyroid. So everything is a two-edged sword. So now I've talked a lot about some other disorders, and I wanted to spend some time on anxiety. And here's a paper that I found on the efficacy of treatments for anxiety disorders it's a meta-analysis, of course, which is from 2015. And so they had quite a few patients. The total number of patients for psychotherapy was almost 7,000. For medications, 28,000. For combinations, 2,380. Total number of patients, 37,333. That's a pretty good number. And so here's what they found. And so you might wonder, what does this all mean? Well, a Cohen's d of 1.0 would mean that something is not effective. And so the higher the Cohen's d score, the more effective something is. And you can see that drugs were effective with high scores for anxiety. Now, because I think in my experience, long-term psychotherapy works better than drugs. And the majority of these studies were less than 12 weeks, the drug studies. And I think that's really not a lot of time. But so what it does say is that you get short-term benefit from drugs, that they work quicker than psychotherapy. And I suppose we acknowledge that when we talk about fast medicine and slow medicine, that psychotherapy and lifestyle change is slow medicine. Drugs are fast medicine. And so you can see from the boxes that SNRIs were the most effective. That would be venlafaxine and duloxetine. Obviously, benzodiazepines reduce anxiety, but with the problems of tolerance and addiction. And in the long term, you can see that SNRIs work better than benzodiazepines. So the other thing that benzodiazepines do is they contribute to dementia, which is a bad thing. And so we don't like to use them if possible. Now, sometimes there's no other agent that will keep people out of the hospital. And in those situations, I do use them. But my go-to medication is venlafaxine. Now, it turns out that actually quetiapine or Seroquel is more effective than SNRIs for treating anxiety. But the side effects are enormously worse, and the discontinuation rate is much higher. So that's just something to keep in mind. Also, pregabalin is as effective in another meta-analysis in treating anxiety as SNRIs, and perhaps more effective. But it's a controlled substance, and if you take all of it at once, it makes you high, though I don't recommend taking all of it at once, though people have been known to. And, but it can be, it's been shown to be quite effective for anxiety. So as we go down the road, we see that CBT plus any drug is almost as effective as benzodiazepines and SNRIs alone. And if you look at the arm, sometimes more effective. this is followed by SSRIs and then by tricyclic antidepressants. So now we're moving into the 1 to 1.5 range, which is relaxation training, CBT, placebo, group CBT, psychodynamic psychotherapy, non-face-to-face therapies, which is apps and things like that. And then things that are ineffective are being on a waiting list and psychological placebos. So now there are other meta-analyses that show that after 16 weeks, psychotherapy is more effective than medication. But if you need to do something quickly, obviously medication is the way to go, while we teach them relaxation and other techniques. So, so in general, drug studies are shorter than psychotherapy studies, 9 versus 12 weeks. And the psychotherapy studies had a mean duration of 21 weeks. So, of course, psychological therapy trials have smaller sample size than drug trials because it takes more time. And this is what I mentioned before. Other comparison studies have shown psychotherapy consistently superior to medication, but only after 16 weeks. And that's 16 weeks of coming every week. So here's another meta-analysis for generalized anxiety disorder. 79 randomized controlled trials with 11,000 participants looking at efficacy of psychotherapies or medication. So psychotherapy showed a medium to large effect size. And the effect size really is what it says it is. It's how effective, how large is the effectiveness of this particular intervention. Medications showed a small effect size on the outcomes of generalized anxiety disorder. And so psychotherapy really works, and it takes time. And it works better than medication, but over time. And for depression, psychotherapy showed a medium effect on depression outcomes, as did medications. Now, what's also interesting is, as I mentioned in the first presentation, predominantly medications' effect on depression is from the placebo effect. And my colleague and wife, Barbara, has been developing the notion that the reason for this is that there isn't such a thing as depression, that it's a state of giving up and not a thing in and of itself. So, but more about that later when she can present her thoughts on this. And of course, younger age was associated with a larger effect size for psychotherapy. So now we have another series of meta-analyses in which randomized controlled trials of medication versus combined medication and psychotherapy among people with a diagnosed depressive or anxiety disorder. So there were 52 studies with 3,600 patients, 32 on depressive disorders and 21 on anxiety disorders and 1 on both. So, so pharmacotherapy appeared to work with a moderately large effect size and a number needed to treat of 4 people. meaning you have to treat 4 people for 1 person to improve. And combined psychotherapy and pharmacotherapy, however, was superior to medication for major depression, panic disorder, and obsessive compulsive disorder. And here you can see some changes in placebo effect. So lo and behold, the placebo effect has been getting stronger from 1980 to 2015. And now, is this just because there's more studies? Well, I don't know. But it appears like the slope of the line continues to increase. And you can see in the decade of 1980 to 1990 that placebo effect was, averaging around no effect. And you can see that by 2010, it's almost a moderate effect size with the Cohen's B-score of 2, and it continues to arise. So it's arising. The slope is 0.056 per year, and I have no idea why the placebo effect is getting more powerful. Is it advertising for drugs on television, which also started around 1980? Let me know what you think. So here was a study of psychological therapies versus control conditions. And you can see that CBT is dramatically better than being on a waiting list or getting a psychological placebo, and still pretty powerfully better than getting a pill placebo. Same thing with group CBT, except that group CBT was about the same as getting a pill placebo. Relaxation was a lot better than waiting list, and apps, non-face-to-face therapies, were a lot better than being on a waiting list. And so, the logical thing to conclude from this is that if you have to put someone on a waiting list, give them an app to play with and teach them how to use it while they're waiting for their intake. So, what about bipolar relapse? So this is the STEP BD study of bipolar relapse. It was 1,469 patients with bipolar disorder. They showed a 48.5% relapse rate within 2 years. And the finding was that they relapsed more commonly into depression than mania, that lamotrigine was better than any antidepressants for preventing relapse, and that recurrence was common and highlighted the need for more treatment options. And my more treatment options would be the various psychotherapies and lifestyle changes that we talked about in the first episode of this presentation. So many of you may have heard of the Katie study of antipsychotics. It was the largest and longest study of its kind. 1,400 patients with the diagnosis of schizophrenia over 18 months, looking at tolerability and efficacy of medication. Both efficacy and tolerability were poor. 74% of the patients stopped taking their medications, and 64 to 70% had substantial side effects. In this Katie study, the first generation antipsychotics were as good as the second generation antipsychotics. So the old drugs performed as well as the new drugs. And I think this is really important because it shows that we need to think outside the psychopharmacology box for schizophrenia, whatever that is. And I'm not sure what it is. But the medications don't seem to be that effective. Now, in meta-analyses, they do work, but over 18 months, the efficacy fades and the tolerability fades. So while the meta-analyses over, of studies over 12 weeks show efficacy, the Katie study over 18 months showed poor efficacy. And to me, this says we need to do more than just give people medication. One of the objectionable side effects is extrapyramidal side effects, and this is abnormal involuntary movements. Prevalence is considerably high. So many of you know what Parkinson's disease is, but these medications produce drug-induced Parkinsonism. So Parkinson's disease, but caused by the drugs that you're taking. Akathisia is restlessness, being unable to sit still, constantly being in motion. And this is the second most common motor side effect. And 1 in 13 patients experience permanent movement, abnormal involuntary movement disorders, also known as tardive dyskinesia. Tardive means late, dyskinesia means disorder of movement. Sounds really sophisticated though, doesn't it? Rather than saying a late disorder of movement. And so thinking about which antipsychotics have the least side effects and also keeping people on the lowest possible doses seems to be really important. What about injectable antipsychotics? I tend to steer clear of them because I like to be able to lower doses when needed. But the studies have shown that in clinic populations, not necessarily my populations, but in university clinic populations, that injectable antipsychotics are associated with improved adherence. In other words, people take them better and longer. And also improved clinical benefit, presumably because they adhere to them better, including reduced numbers of hospitalizations and emergency department admissions. So, so this particular review and meta-analysis from 2021 found that even though injectable antipsychotics cost a lot more, that they result in lower medical costs from hospitalizations and ER admissions, resulting in no difference in total healthcare costs. However, one could argue that the level of suffering for people is lower with long-acting medications because they're not going to hospital and emergency department. So that's something to think about. Now, there are other ways to work with psychosis. And one of these is omega-3 fatty acids. And there was a placebo controlled trial, double-blind, randomized, etc., over 12 weeks, with people on the verge of becoming psychotic. They were ages 13 to 25 years old, 81 patients. They were given 1.2 grams per day of omega-3 fatty acids for 12 weeks. And they were monitored over 40 weeks. And the progression to psychosis was 4.9% in the EFA group versus 27.5% in the placebo group. So omega-3 fatty acids work. What about sleep? I've got a little bit more to show you about sleep. Here's a meta-analysis from Canada, conducted by at least one person who spoke Chinese or read Chinese, because they looked at 5,000 articles, 44 in English, 28 in Chinese, of that were included. So 72 total included studies. And they looked at complementary and alternative treatments for insomnia among people with depression and anxiety. And they found that all of the CAM modalities that they studied yielded statistically significantly moderate to large effect sizes on sleep, depression, and anxiety symptoms. And mindfulness-based treatments were better than placebo controls. So, these are their main points. Acupuncture and/or acupressure and mindfulness-based treatments are effective in improving mild to moderate insomnia and sleep disturbances comorbid with anxiety and depressive symptoms. Covariates, things that matter, include baseline symptom severity, study quality, publication language, and they found that Chinese studies showed greater efficacy than English language studies. And my supposition is that Chinese patients are more primed to respond to acupuncture, acupressure, and mindfulness-based treatments, because expectation matters. Okay, so just to show you some of the things that they did acupuncture, they did mindfulness-based meditation, they did massage therapy, and all of them worked. So acupuncture and/or acupressure, quite effective, good effect size. Here's looking at mindfulness-based interventions, and the way to read one of these graphs is the zero line is where nothing happens. And so if it's less than 0, if the standardized mean change score is less than 0, it means people improved. And so -1 would be 1 standard deviation from the mean, which in this case would have been set at 0. So, so we can see that the studies average close to that. And actually, that's pretty impressive because there really aren't good drugs for getting people to sleep. Some people use trazodone, which is a SSRI, and it does make you sleepy, but the sleepiness is a side effect that wears off. And some people use mirtazapine, a unique antidepressant, which can make you sleepy, and that side effect also wears off. Some people use Seroquel, quetiapine, whose main side effect is sleepiness. But if you take it long enough, that side effect wears off. So the only things that seem to work are the Z drugs, the zolpidem, zolpiclone, Ambien, and yet these drugs are associated with dementia more strongly even than benzodiazepines, and have significant other side effects, as well as tolerance and addiction. So, so it's hard. It's hard to force people into sleep. And I suppose you could come up with a 4-month combo of giving someone trazodone for the first week, Seroquel for the second week, mirtazapine for the third week, and maybe an antihistamine like Benadryl, diphenhydramine, or hydroxyzine for the fourth week, and then recycle through that, and maybe that would keep working. I've never tried that, but I've thought about it. You know, I'm more inclined to the mindfulness-based intervention, acupuncture, and acupressure world. So I wanted to finish by talking a little bit about epigenetics. And epigenetics is powerful because it's how our ancestors' experiences are transmitted to us. And so Holocaust, the children of Holocaust survivors behave as if they were in the Holocaust. And the children of residential school survivors behave as if they had gone to a residential school. And so much of psychiatry is about epigenetics and not normal genetics, usual genetics. And experience changes the epigenome. So we used to talk about psychotherapy being a corrective emotional experience. And when that happens, the epigenome changes. And that's powerful. So I just wanted to finish by talking about just how I would choose medications. So let's say that someone is presenting in a state that could be characterized as psychotic. And what do I mean by that? I mean that their thinking is so disorganized that they're hopelessly impaired from doing anything, getting anything done, taking care of themselves, making decisions. Or maybe they're paranoid. You know, I have a client right now who believes that she's being followed by a mafia guy, and that he's followed her from a major big city in the South, where everything is south of Maine in the United States. But he's followed her from a major big city in the South through multiple moves. And he's hired someone to be in the apartment next to her and cause noise. And that people are, that the mob has tapped her phone and they're listening to all of her conversations. And she's paralyzed with anxiety and indecisiveness about what to do. So because this is also real to her, it's very difficult. And so, you know, I convinced her to try aripiprazole to reduce her crippling anxiety. So we started off with 2 milligrams, which is a small dose. And after a few days of that, for the first time, I got a relatively reasonable history though somewhat tangential. But before that, I had virtually no history. And it didn't overly sedate her. So now we're going up to 4 milligrams and see how that goes. Now, why would I choose aripiprazole? Well, it's among the medications for psychosis that have the least side effects. It's among the medications with the least weight gain. Lorazepam has the best side effect profile, but is associated with weight gain. And it was really important to her to not gain weight. The other one that is associated with minimal weight gain is ziprasidone or Geodon. Now, there's a new medication that I just learned about, Rexulti, and a colleague of mine believes that it's really good in terms of no sexual side effects, no weight gain, quick onset of action. We'll see. We'll see how it turns out. So I work in a Medicaid environment, so I'm sort of stuck with what Medicaid will cover. Here we call it main care. And generally, they don't like lorazepam because it's very expensive, and they certainly don't like any of the newer medications that I just mentioned. And they don't like Rexulti. So for main care, if I can, I'll start with aripiprazole. And if main care won't approve it, I'll go with risperidone, which is not one of my favorites. But if people have side effects to it, then I can get permission to use something else. Okay, so let's say someone is anxious, crippling anxiety. My go-to is probably going to be venlafaxine, unless their anxiety is tremendous and they're not sleeping, in which case I would start with quetiapine and perhaps eventually transition them to venlafaxine or add it and slowly decrease the dose of quetiapine. So what about depression? Well, that seems to be a toss-up. All antidepressants are equally placebo. So what side effect would I like to give them? Well, if they need sleep or they're nauseated, how about mirtazapine? If they need to be activated and stop smoking, well, maybe bupropion or Wellbutrin. If I just want a good placebo, maybe Prozac or fluoxetine. Now, people don't realize that the SSRIs are as likely to cause bleeding difficulties as the non-steroidal anti-inflammatories, and also to cause intestinal and stomach difficulties. So that's something to keep in mind. Also, sexual side effects. Bupropion has the least sexual side effects, followed by potentially mirtazapine. And you have to ask people about sexual side effects because they never tell you. They just stop taking the medication. And I'm starting to believe that if somebody's misery is severe enough, just go straight to one of the antipsychotics because they do have efficacy. And low dose aripiprazole or lurasidone or Rexulti seem to be the way to go in my mind. If there's some indication of bipolar symptoms, lithium is worth a try. And I'll sometimes use that to augment the effect of antidepressants, as I will use antipsychotics to augment the effect of antidepressants. What if people just rapid thoughts, rapid movements, what we might call mania? I think that's where the anticonvulsants come in handy. And if symptoms are severe, I start with valproic acid or carbamazepine, Tegretol. If symptoms are not quite so severe, I think lamotrigine and topiramate have fewer side effects and are worth considering. So, that's a little bit about how I think about these things, and I'm happy to engage in further discussion. And I thank you for listening if you've gotten this far. And that's the end for tonight.